Hi everyone, the topic today is diagnosis of anemia. I've made some presentations on anemia before. You can check my channel and I'm going to make more very soon. Okay, about diagnosis of anemia, let's go. You may or you may not be able to make the diagnosis of anemia even with your hemoglobin level, total red blood cell count, and hematocrit. Why that? Yes, you can make the diagnosis, but if there is massive bleeding and you have taken the sample to measure these parameters into the onset of the bleeding, you are not going to get the exact picture because you'll still be getting the picture of the parameters before the onset of the bleeding. So, immediate bleeding, massive bleeding, and you take sample immediately, and you want to know the value, the correct values, you are not going to get it. Also, when there is blood transfusion, if you take the sample immediately after transfusion, you are not going to get the true picture of what is going on in the patient. You are likely going to get the values of the sample you transfused. So there should be time lag between the onset of massive bleeding and after the transfusion before you can get the exact and correct picture. That's it. Okay, let's go. In males, hematocrit is between 40 and 48%. So anything less than 40% is anemia. And hemoglobin less than 13 grams per GL is anemia in males. In females, when hematocrit is anything less than 36% or hemoglobin is less than 12 grams per DL, that is anemia. We also need to know MCHC, MCH, then MCV, which is the mean corpuscular volume, and the normal range is 80 to 100 femtoliters. When mean corpuscular volume is high, that is megaloblastic anemia. When MCV is low, that is microcytic anemia. We need to know the level of reticulocytes, the features of hemolysis that I'm going to talk about in a bit, and if there's any ongoing bleeding. Megaloblastic anemia, when MCV is greater than 100 femtoliters, that is mainly going to be found in folate deficiency or vitamin B12 deficiency, majorly. But that might not be the end of possible causes of megaloblastic anemia. It's also possible in elevated homocysteine and hypothyroidism, liver disease, myelodysplastic disorder, and medications like antifolates. Example is methotrexate or even chemotherapy or Sovamers. All this will affect either the level of folate or the level of B12. It's possible there's anemia and MCV will be within the normal range of 80 to 100 femtoliters. If that is the case, we need to suspect bone marrow suppression. Or is there any renal failure going on here? Because erythropoietin is produced by the kidney. And is there any ongoing bleeding that is occurred or even known? Then we check for reticulocytes level. That will give a clue. When the MCV is low, that is microcytic anemia, then the value will be less than 80 femtoliters. Okay, are we dealing with iron deficiency anemia? Because that is going to be the first thing that's going to come to the mind. Microcytic anemia or iron deficiency anemia. Oh, okay, let's rule that out. How do we do that? Let's check total iron binding capacity. When we have iron deficiency anemia, we expect the rate or the level of iron binding capacity to be up because there should be the readiness to bind the more. So higher level of TIBC is an indication. Then when we check the level of iron, it's going to be low. And of course, the ferritin will be low. So when we have high TIBC, low iron, low ferritin, yes, iron deficiency anemia. But if that is not the case, we'll look for other possible causes. Could it be thalassemia? Is this person from the Middle East or Mediterranean? And what is the genetic history here, family history? We'll check that out. Anemia of chronic disease, we need to rule out long-term disease in this individual. Is there any rheumatoid arthritis, diabetes mellitus, any chronic disease could give this kidney failure and so on. Where has this person been living? The type of job that has given exposure to lead poison. Are we dealing with lead poison here? We can easily assess the level of the lead. Sideroblastic anemia, for the same purpose, just to be sure that we know the exact cause of the microcytic anemia. Okay, are we dealing with hemolysis? Because here is anemia. We've been doing everything from now. We've not been able to get the diagnosis. Okay, suspecting hemolysis. All right, let's do some few things. How about the reticulocyte count? Is it increased? Yes. Okay, it's pointing to that. How about the level of unconjugated bilirubin? Is it rising? Yes, it's pointing to that. How about the level of lactate dehydrogenase? Is it increasing? Yes, it's pointing to that. And when we check the haptoglobin, we expect it to drop. We expect the level to decrease. And when we have that, then we begin to suspect what could be happening. Is it hemoglobinopathy? Then if that's the case, is it sickle cell disease? Because from the history, from the physical habitus, we might be able to get that. And of course, you can just do genotype, assay and everything. Then is it thalassemia, Middle East, Mediterranean, the family history and so on. Hemoglobin SC, hemoglobin SG and so on, spherocytosis could be responsible. That is not the end when it comes to hemolysis. Let's see check. Could it be infection? Could it be HELLP syndrome, particularly in a young woman that is pregnant, hemolysis, elevated liver enzymes, and low platelets? It's a big problem. And could this be disseminated intravascular coagulopathy, thrombotic thrombocytopenic purpura? We're still ruling out the possible causes of hemolysis. Okay. Are we dealing with hemolytic uremic syndrome? Could this hemolysis be as a result of medications that this woman is taking? We have to check all those medications and find out we are not subjecting this woman to hemolysis and we are still thinking we are helping. Okay, but sometimes we might not know. It could be metabolic and our medication is now causing trouble, particularly when it comes to G6PD deficiency, that is glucose-phosphate dehydrogenase deficiency, when they cannot take certain medications or they cannot eat certain foods. I have a full presentation on glucose-phosphate dehydrogenase deficiency is out there. Please check it out. You have the full list there. And this could be as a result of exodus monophosphate and glycolytic pathway that will involve G6PD and the rest. And don't go yet. Okay, we're still talking about hemolysis. Could this be autoimmune hemolytic anemia? Oh, we'll do CONT test, right? Okay, when we have gone around and we can't get the diagnosis, what? Wait, pause. Autoimmune hemolytic anemia is possible. Okay, we have taken the sample. We want to know the level of reticulocytes. All right, there are two things to do here, okay? And the first thing is you're going to get the value you've gotten, but that's what we call corrected reticulocyte count. That is what we're going to report. So it's a simple mathematical procedure but you need 3 items. You need to know the reticulocyte count, you need to know the hematocrit, and divide the multiplication of those two by the average normal level of hematocrit in that individual's gender and age. And I will give you an example here. I've taken the sample of my patient. The value of reticulocyte is about 4%, and this is a man, middle-aged man, with his own hematocrit at 38%. So I'm going to report the corrected reticulocyte as the reticulocyte count of 4% multiplied by the hematocrit of the same man divided by what I will expect as average normal. So at this stage, for him, I will pay 48%. Some will pay 45%, or as the normal hematocrit for this man at 50 or 60. So I'm going to get 4 multiplied by 38 divided by 48, and that will give me 3.1. The normal range is about 1 to 2%. The normal range of reticulocytes is about 1 to 2%. So mortalities, we put it at 0.5 to 2.5. No, just different books will give you different values. That is in adults. In children, the value is expected to be between 2 to 6, or sometimes 2 to 5% is higher in children, or let me say newborn, infants. Reticulocytosis, that is higher reticulocyte count. And why are we going to have this? Under which situations are we going to get this? It's possible under hemolytic anemia. It's possible when there is hemorrhage, when there is high altitude, or there is administration of erythropoietin. Maybe there is kidney failure, the normal production of erythropoietin is down, and you are now giving the exogenous erythropoietin, and you check for the reticulocyte level. If it is high, yes, what do you expect? Okay, or high altitude, living top of Mount Everest on vacation and decided not to come back home, or perpetually that is your territory. People in Kenya, and Ethiopia, and in mountainous parts of the world, they have this, and that is why they could run long distances and be winning, because they have polycythemia. So they have this high level. Then somebody bleeding, hemorrhage, and the bone marrow is trying to make up for the loss, or there's hemolysis somewhere, blood is getting lost, and there's no this effort to replace. Then when there is iron deficiency anemia and you are treating the deficiency with iron supplement, then this is a sign that your medication is working. The level of reticulocytes will be high. And maybe there's megaloblastic anemia, folate deficiency, or vitamin B12 deficiency, and you are given the exogenous supplement to meet up with those deficiencies. Then you assay your reticulocytes is likely going to be high. Okay. Sometimes when you assay the reticulocytes, the level is going to be very low, and that is reticulocytopenia. But you might not be so shocked if there is pancytopenia, which means all other cell lines are also down. When all cell lines are down, when the reticulocytes are also down, then you start thinking of few things. Could this be aplastic anemia? Could this be leukemia? Could this be tuberculosis? Could this be amyloidosis, sarcoidosis, chemotherapy suppressing the bone marrow, or bone marrow infiltration, or paroxysmal nocturnal hemoglobinuria? However, the story is not going to end here. What will happen again? Yes, it could be reticulocytopenia at low level, but It is not pancytopenia. In other words, not all cells are affected. So it's only the red blood cells that are affected. Then the thinking will be a bit different. Could this be anemia of chronic disease? Could it be renal failure? Could this be liver failure or red cell aplasia? So reticulocytes are young red blood cells, and the level is expected to increase when there's a fall in red blood cell count. But if it is not high when there is a fall in red blood cell count, then there is problem with the bone marrow itself. It means there's bone marrow production impairment. Something has happened to the bone marrow. In conclusion, for now, and I've just said for now because I'm not going to round up on anemia just like that. There are more things to talk about when it comes to anemia. That's why I'm not going to rush to make everything into one presentation that's going to span 3 to 4 hours. No, that would be boring to you. So I'm going to end this now, but very soon there'll be another presentation on anemia in children and more, particularly anemia in pregnancy and so on. Thanks for listening to my presentation. Kindly subscribe so that I can get this as soon as they are published. Thank you.